Gott. I would like to introduce you again, Randy. Your word shouldn't be a word now. Randy's from the University of Iowa. He's born and bred in Iowa, and you have done scientific work for over 25 years.
30 years.
30 years even. And numerous publications, and you've been teaching all over the world, not only here in Sweden, also in Shanghai for numerous years. And this is the fourth time you're here, so we're fortunate to have you. And I think your main interests are optic nerve disorders, partly traumatic brain injuries, and pupil disorders, but also numerous interests in other fields. And you're also developing new techniques that hopefully will be available to us in the future. So I hand it over to you now to continue. That wasn't too bad, was it?
No, that was not embarrassing, thank you. Okay, good morning. I thought we would cover a little bit more in depth about the afferent part of the pupil light reflex, and then we'll cover the efferent part with a lot of different cases to illustrate causes of efferent pupillary defects. Rafi's also sent out a PDF, which is focal points sponsored by the American Academy of Ophthalmology on how to approach anisocoria. We'll be covering some of that, but it's a nice PDF for you to refer to. And some of this we can skip through because you've already become experts now. I just wanted to review briefly the pathway, the neurologic pathway of the pupil light reflex. And basically, this is from Irene Lowenfeld's book. Irene Lowenfeld was a huge person in the pupil area of research. She passed away about 8 or 9 years ago, and she published a huge encyclopedia just on the pupil. But like the visual pathways, the afferent part of the pupillary light reflex starts in the retina, and what we'll cover later in this presentation is these specialized retinal ganglion cells that subserve the pupillary light reflex and their properties and how we can take advantage of that clinically. And just like the visual fibers, the pupillary fibers cross in the chiasm, and there's a non-decussating portion from the temporal retina, which is the nasal field. And the first part of the synapse, unlike the visual fibers, which synapse in the lateral geniculate, the pupillary fibers peel off here, off the optic tract, in what's called the brachium of the superior colliculus. And they synapse in a group of neurons here called the pretectal olivary nucleus. And those neurons also have a crossing or decussating pathway that goes to the Edinger-Westphal nucleus and a non-decussating or non-crossing pathway. And so a lesion right here would take out the pupillary light reflex, for example. But the fibers for the near pupillary response that are supranuclear that also come into the Edinger-Westphal nucleus come from other centers of the brain. So if a lesion occurs here and you lose the light reflex, with focusing it near your pupil still constricts. This crossing pathway is about 50-50. Do any of you have cats at home? Anybody a cat owner? Okay, so cats love you to do things to them. Not. But if you put one eye towards the light, you'll induce an anisocoria. Humans, you won't do that. Because cats have a greater crossing pathway, not only in the chiasm, but also here. So if you shine a light in this eye, most of it goes over to this side and crosses back, and so you can induce an anisocoria. So you'll see an anisocoria depending on where the lighting is in lower animals like a cat. But humans, mostly it's 50-50. There's a few exceptions. So the point is that with an afferent problem, whether it's retina or optic nerve, it really shouldn't induce a difference in pupil size, because whatever's coming in or wherever's not coming in, it's distributed equally on the efferent side of both pupils. So that may be obvious to you, but just worth noting again. We covered yesterday why we're measuring the afferent pupillary defect, the relative afferent pupillary defect relative to the other eye, because it gives a good input of the whole visual field asymmetry between the two eyes. And if you see an RAPD, it could be in the retina or the optic nerve or the anterior visual pathway. So it could be the chiasm, the tract, any of those. But because this pathway is mainly pre-geniculate, a cortical lesion would not normally give a pupillary deficit. There's a few exceptions to that. Interestingly, if you try to do pupil perimetry, so give small spots of light, and then measure the pupil response, if you have someone with a cortical occipital infarct or tumor, they will not have a pupillary light reflex to small spots of light, but they do to a full. So there actually are some projections to occipital cortex, but probably not so much from the retinal ganglion cells that subserve the pregeniculate, that's from the visual ganglion cells that go to the occipital cortex, and then they send input to the Edinger-Westphal. So just a few exceptions, you might hear about it. And yesterday, some of us, we were talking about why do we have to go to the trouble to measure it. And remember that it's one of the few non-invasive, objective measures of input that's quick, and you can do it without any special equipment. And then we talked yesterday at quite a length about why we want to quantify it in log units, and I'll show some more examples. And really you should be looking at that in terms of whether it coincides with the visual field testing. It kind of helps you know whether that's reliable and whether it's trustworthy. And then obviously, as some of you will go on to do cataract surgery or evaluate cataract patients, if you see an RAPD in a pre-cataract patient, you should pay attention, because cataracts do not produce relative afferent pupillary defects. Yes?
But why do the filters then produce it? Why do filters, if the cataract doesn't?
That's a good question. So the question is, if a dense brunescent cataract doesn't produce an RAPD, how come you can induce one with a filter? And the answer to that is that think of what happens with a dense brunescent cataract that's there for some time, for hours or months, is what do you think the retina does in response to a decreased input? It has a gain control, right? And so it upregulates. So if you held a filter over one eye for long enough, the RAPD would go away, right? So now it's interesting, if you have a white cataract, which we don't see very often anymore because they're taken out before then, but a white cataract can produce an RAPD in the opposite eye, because what's happening is it's dispersing the light all over the retina from a light source, so that actually that eye reacts more to the light relative to the other eye. But you won't see that often because you don't see white cataracts very much anymore. But don't be surprised if that happens. That would give about a 0.3 log unit RAPD in the other eye if it's a white cataract. But very good question, thank you. So we said the clinical significance, the main thing is proportional to the degree of asymmetric visual input, may be caused by retinal or optic nerve damage, not increased by corneal or lens opacities, and may be used to identify change over time, worsening or improvement. And then the last one, if you have a patient with a homonymous visual field defect, and we'll talk about that in a second, and they have a relative afferent pupillary defect, that's very localizing to a tract lesion. And we'll talk about why that is. It might not be that obvious to you. All right, we already talked about this, so that's review. You know about the filters now. You know about tilting the lens or using it to bring out an RAPD that's mild. And we've already gone through these videos. Here's one that I didn't show yesterday because we were talking about when both pupils are doing the same thing and there's no efferent problem. This is an example of a patient who had both a left efferent and a left afferent. And I just want to show you the video so you get a feel for, why you'd want to just watch one pupil in a case like that. This was a patient who had a retinal detachment and had successful surgery, but post-operatively had a very high pressure rise. Both central retinal artery occlusion, and because of the high intraocular pressure, it caused ischemia of the iris on that side. So what you'll see is the beginning of this video, we're going to turn on the lights, and you'll see that causes an anisocoria to become more apparent. And then as we go back and forth with the light, you'll have to just watch the right pupil, because if you watch the direct response, you might overestimate the RAPD. So let's just take a quick look at that video. So we're going to turn the lights on, and now you can see there's an efferent defect on the left side, right? Because we induced an anisocoria with bright light. So now when we go back and forth, you should just watch the right pupil. And you see that it's so big of an RAPD that pupil dilates. So there's a decrement of light when you go over to the other eye, so much that the pupil dilates when you go to the left eye. And you watch, as we add filters, instead of it dilating, you'll start to see an initial contraction as we get closer to the balance point, as you would see in a milder defect. So here's a 0.6 log unit. Now you're seeing an initial contraction when you go over to the other eye. But it's not quite enough yet. It still contracts more when you shine the light in the right eye. I think it's obvious. And here's a 0.9 log unit. So almost there, but still, if you go back and forth a few times, the pupil reacts more when we're going over to the right eye. And then we're going to go to a 1.2 log unit defect, or filter, which now pretty much balances it. Now that pupil reaction, that initial contraction, looks about the same, no matter which eye we're shining the light in. Yeah? And then I'm going to add a filter, and I'll stack it on top of the other one to get 1.5. And now you see, this is the eye that's not reacting as well when we go over to that eye. Reacts more when we go to this eye. So we've balanced it. We've gone too far, so it's a 1.2. But that's an example of why you'd want to watch just one pupil when you're doing the test. I want to show you one other interesting aspect. This is an automated machine that measures an RAPD, and it dims one eye with respect to the other, and then switches it and finds the balance point automatically. I want you to just watch this for a second. So the light's going back and forth to the right eye and to the left eye. And you're noticing when the light is increasing one eye over the other, it looks like there's a difference. And I'm going to repeat this video, but I want you to watch it in a different way. I want you to watch it one more time, but now I want you to just watch the eyelids, especially the lower eyelids. What do you see? Whoa! There's an eyelid response to light in many people. And we're trying to take advantage of that now so that you can automate the fissure change when you shine a light in the eye. So if you have a patient that's dilated already and oops, I forgot to check the RAPD, you could potentially use the eyelid. And I'll show you an example of a tracing. So here's a patient who had a left optic nerve problem. And this red tracing is the pupil reaction when the light is shined in the right eye, so a big pupil contraction, right? So this is size of the pupil, and this is just time. And then when the light is shined in the opposite left eye, there's a smaller reaction. And then we're going to do the same thing with a little bit brighter light, and now here's the eyelid response to the good eye and the eyelid response to the bad eye. So in many people, there's a photic eyelid response that we can take advantage of. Interesting enough, it's inhibited more in some people than in others, but when you see it, you can remember to use it if you need to.
Is it proportional to the RAPD?
We're studying that now because it's not clear if it's mediated by the same retinal ganglion cells or not, and whether disease affects, if it's a different one, that it may affect it in a different way. We don't know for sure. But that's an area of ongoing research. Next year I'll be able to tell you more, but you won't be here. Okay, good. We were talking about an alumni meeting in the future. So let's just talk briefly about an optic tract lesion. Because I said, if you get an optic tract lesion, so here's a right optic tract lesion, and you get a left homonymous, that you get an RAPD. And you're thinking, why? Because you're thinking you're losing a half field on each side, so you're stimulating the remaining working field. Why would that give an RAPD? It's not very intuitive. And so, for example, the idea is that here there's a left homonymous, and here we're shining light in the left eye, and we're getting a pupil reaction, but it's not as much as when we shine the light in the right eye. You can see the amplitude's greater. And so, again, you might wonder, why is that? But let's recall something. First of all, recall what the normal field of vision is. Remember, if you look at it in terms of the amount of real estate covered by the nasal field and the temporal field, we all have more visual field in the temporal part of our field. That goes out to 85 or 90 degrees. Nasal field goes to about 60 degrees, right? And so on top, on the left is your normal Goldman visual field. You can see on the temporal side with the physiologic blind spot, there's more isopter there, right? And so to the right of that is a patient who has a complete homonymous. And so you can see the eye with the remaining temporal field has more visual field than the eye with the remaining nasal field. So when you're shining the light back and forth, you're stimulating the remaining temporal field input compared to the remaining nasal field input. And the temporal field has more working area, right? And so it's going to give a greater pupil response. So you'll always see an RAPD in the side that has the temporal field loss. So that's an easy way of remembering that. Just remember how much visual field you have in the nasal and temporal field. Why am I making a big deal about that? Because if you see a patient like that on call or in the emergency room, and they have a homonymous, and they have an RAPD, you know immediately it's very localizing. You can tell your neurologist, this is a tract lesion, and it's going to be probably middle cerebral artery stroke or lesion in that area, not occipital. A lot of you were asking yesterday, how much of an RAPD do you get if you take out certain parts of the visual field? And this is a rough approximation that was done about 35 years ago with patients that had different retinal detachments covering different amounts of retina. And if the other eye is normal, if you take out the whole macula, you would probably expect to have about 0.6 to 0.9 log units. And the reason is that there's more pupillary ganglion cells in the macula than in the periphery. So there's more valence or more pupillary input from the macula. just like in vision. And then for each quadrant, it's about 0.3 log units. So this is just a rough approximation. And all this talk is in your PDF that you have, so you can look at it later if you can't remember what each quadrant is worth. But it's just a rough approximation to give you an idea when you see, because some of you are asking how much visual field should I expect if there's a 0.9 log unit. Well, you know, if it's complete altitudinal, it might be 1 log unit or 1.2 log units. Let me explain this graph. It looks a little busy, but what we did was we took patients that had structural loss by OCT, who had nerve fiber layer thinning, okay? And we looked at the difference in the average nerve fiber layer thickness between the two eyes, between the right and left eye. So applying the difference in microns, 20 microns difference, 40. And this is if this is left minus right. And then we also did the same thing with mean deviation in decibels. So remember we talked about that mean deviation is in units of decibels. And then we also quantified the RAPD and just multiplied it times 10 to get decibels. So obviously a 10 decibel RAPD is a 1 log unit. And what's remarkable in this small series of patients is that, first of all, both the mean deviation and the RAPD has some relationship to the nerve fiber layer, which you'd expect, because you're losing axons. You should expect to lose both visual field and RAPD, but it's about the lines best fit lines are about the same proportion. So these two are really related to one another, as we talked about yesterday roughly. If you look at the ganglion cell layer in patients who have ganglion cell layer loss, so that'll be the central 10 degrees, there's a pretty good relationship there too. So here's computerized RAPD in log units, and this is the asymmetry between the two eyes and ganglion cell layer thickness. So I'm just making the point that when there is structural loss, the RAPD is somewhat proportional. The exception to that would be someone who has a compressive optic neuropathy, who maybe doesn't have structural loss, still could be reversible, and you have a RAPD. So be aware of the patient who has visual field loss and RAPD and a normal OCT. You should be much more worried about that patient than someone who has structural loss, because that kind of tells you that you've got an asymmetry that's probably reversible, right? And that person really needs to be investigated. I want to spend a little bit of time giving you a little science and show how it's related to the clinical application. So in about 2000, it's been a while, 2003, 2004, there was an interesting observation. That was at a time when scientists were trying to investigate the molecular biology of retinitis pigmentosa. And they were making genetic models to duplicate the human models in mice. And so we have these number of genetic defects that were made in mice to duplicate the ones found in humans. And so these mice had a fairly rapid retinal degeneration that happened over the first month or two of life. And so they were using them as a model and showing that there was complete photoreceptor loss histologically. They had a flat ERG. And, but curiously enough, these nocturnal animals still had a nocturnal sleep cycle, even though they lost all the photoreceptors, which was very unusual because that was not expected. And some bright laboratory assistant shined a bright light in the eyes and saw that they still had a pupil reaction. Because up to that point, it was thought that all input for vision and pupil originated in the photoreceptors. And so that was a big surprise. And that caused a lot of investigation to find out what was it in the retina that was responding to light when you lose all your photoreceptors. And not only that, it was found that the response of the pupil was wavelength dependent. So you got a much greater pupil response when the light was blue compared to red, gave hardly no pupil response. And that led to the discovery of, you may have heard about, a separate subclass of retinal ganglion cells that contain a primitive pigment called melanopsin. So melanopsin, from an evolutionary standpoint, was the first photopigment in eyes of lower animals before we got rods and cones. And melanopsin is present in about 1% of retinal ganglion cells. And what's interesting about these neurons is that if you trace their axons down the optic nerve, they go to two main locations. There's a couple other locations, but the two main locations is the suprachiasmatic nucleus of the hypothalamus. That's your circadian rhythm area. So this is the main neuron that gives light input to set your daily rhythm. And these axons go to the pretectal olivary nucleus. So this is the substrate for your pupillary response to light. What's also interesting is that you can excite these neurons from photoreceptors, from rods and cones, but also directly by stimulating with blue light, because the melanopsin absorbs light in the blue, mostly in the blue wavelength range. So if you give a bright blue light in someone who has no photoreceptors, you'll get a pupil response. But if you give a red light to the same person, there's hardly no pupil response, because that's going through the rods and cones to that neuron. You following me? And that provides some interesting opportunities. I'm going to show you some examples of how you could use that in the clinic. Let me give you an example. Let's say you have a child who, the question is, they don't see very well. And you're worried, is this a retinal problem or is a tumor, compressing the optic nerves? And you know that you're going to have to sedate them to get an ERG or sedate them to get an MRI scan. And so you're wondering what you should do first. And at that point, the retina looks normal. But if you just check their pupil response, if it reacts much better to a blue light and not much to a red light, you know right away it's a retinal outer photoreceptor problem. If it doesn't react to blue or to red, you know they need an MRI scan because something's going on with their optic nerve, or both nerves. So what's interesting, as I said, is these neurons go to both the suprachiasmatic nucleus of the hypothalamus and to the pretectal olivary nucleus. Very important subconscious areas. And we tested some of these patients extensively. And if you have a patient that's completely blind, NLP, from severe retinitis pigmentosa, let's say Leber's hereditary retinal degeneration, their pupil responds almost normally to blue light, but they don't even know they're seeing it. It's at a subconscious level. And they entrain to the blue light. So that's why patients with retinitis pigmentosa and photoreceptor disease don't have much sleep disturbance, because they're just like the mice. They still will entrain themselves to the daylight and nighttime hours. But if they have optic nerve disease, they're going to have sleep disturbances because they're not getting in phase with the light every day. You might also wonder, well, if it only is 1% of the neurons, how important could it be? And this is from a monkey retina showing the distribution of these ganglion cells and their receptive fields. And what I want to emphasize is that these retinal ganglion cells are different from the other ones because they have huge dendritic receptive fields over many degrees. And all of these dendrites contain melanopsin. So it's not just the cell body. So it's almost like a whole bilayer, both in the ganglion cell layer and the inner plexiform layer. So there's two layers of dendrites. These neurons are bistratified, and all of their dendrites contain this melanopsin pigment. So there's quite a lot of melanopsin in the retina in these two layers. And even though they're only 1% of the neurons, their dendrites have a huge covering of the retina and a large concentration of this photopigment. And you can see here's the neurons in the inner plexiform layer and ganglion cell layer and all their dendrites labeled for melanopsin. And you can see here's a labeling experiment. There's quite extensive. Nowadays this has been so researched in so much detail. There's actually 5 classes of melanopsin ganglion cells that have maybe different projections, or some of them are more responsive to photoreceptors, some are more responsive just to blue light. And so this is a huge area of research that people are studying for different reasons, both for circadian rhythm reasons, and we did some research in Aalborg, Denmark, to look at patients who had depression, to find out, and you have the same problem in Sweden, as you go further north, the daylight hours in the wintertime are very reduced, right? And so the question is, do patients with depression have more susceptibility to depression in the wintertime because they're not getting as much light input? And so depressed patients, we found, had a much reduced pupillary light reflex in the wintertime compared to the summertime. So not only are these important for input, but the amount of input may change seasonally. It's a very interesting area. The way we investigated this was back 15 years ago now, is that we took an ERG bowl. And the modern day ERG bowls are computer controlled, and they're LEDs so that you can control the chroma, or the wavelength of the light. And then instead of an ERG electrodes, we put these iframes that had video cameras and infrared lights so we could monitor the pupillary responses to Gansfeld stimulation in red and blue light. And what I'm showing here is on the top is the pupil response to 1 second lights that are increasing in intensity. And you see how the pupillary light reflex contracts more with brighter light, and it also dilates, fairly rapidly to red light. And to blue light, at the lower intensities, it looks very similar until you get up to the brighter lights. And this is where melanopsin is starting to be activated. So it's a photopic response. It's not very sensitive to low light. And you can see that what happens, the signature, is that the pupil contracts and it stays contracted for quite a long period of time. So when these neurons are activated, they are sustained in their action potentials. And so the signature clinically, which I'm going to show you in just a second, even in a normal eye, if you give a bright blue light pulse, the pupil will contract and it stays small for 10 or 15, 20 seconds. Whereas red light, it contracts and dilates right away. And that brings up the point, yesterday some of you were onto the fact that if you use too bright of a light, even with a white light that has a blue component, the pupils just stay contracted and aren't doing much. And that's part of the reason, is you're activating with a higher intensity the melanopsin ganglion cells. So here's a nice video. What you're going to see is a red light stimulus, and you'll see the pupil tracing response, and then the blue light stimulus. This is a normal person, how much different the response is. So let's look at that. Red light, pupil contracts and then dilates after a second. Here comes the blue light. Contracts, 1 second on, 1 second off, and the pupil just stays contracted. You can see from the tracing there. And it's unmistakable. And if you just plot the difference, you'll see that this is the component from the melanopsin, the sustained response. And this is what people are using now in the psychiatric field, in the neurobehavior field, to measure these responses and how they're affected by different sleep disturbances and how they modulate your wakefulness and sleep. So it's kind of an area that ophthalmology and psychiatry is coming together now. Yes?
Is it possible to run with the jet lag?
Yeah, so that's a very good question. Is people are traveling across time zones, jet lag, and what's commonly used is melatonin, okay, because melanopsin input to the suprachiasmatic nucleus suppresses melatonin release. So when you're going to sleep at night and it's dark, that input goes down and then melatonin levels rise and you get sleepy. And that's why with the Apple iPads and the iPhones, there's a function where it goes to a warmer color screen instead of blue, so that it doesn't keep you awake if you're using your iPad in bed, because you're suppressing your melatonin. And so one way of overcoming that is just to give oral, if you time it right, melatonin. And even some children with sleep disorders are being given melatonin at night to help them sleep. So that's a good question. But it's important for ophthalmologists to have an understanding of this, because you can understand how important the physiology is for, there's so many things that circadian rhythm controls different organ functions, not just sleep. And so this is very important.
I was just thinking that it was more a few years ago that we used handwritten or photocoagulation in much more extensively.
Yes.
Than we do now, that we're more and more replacing it with the anti-VEGF treatment. But is there any correlation between inducing depression in susceptible patients or sleep disorders?
So the question was, before anti-VEGF, we still do a lot of panretinal photocoagulation, and the question is, if you ablate a lot of the outer retina with laser for photocoagulation, are you endangering their sleep cycle? But I guess what I'm trying to tell you is no, because even patients with retinitis pigmentosa can still sink to the light because of these melanopsin ganglion cells, because you're not destroying those. The heat from the laser really destroys the photoreceptor layer, because the laser is being absorbed by the pigment epithelium, and that's the layer that heats up. So the answer to that is no. And then another question that's asked is, most people who are doing cataract surgery and inserting the IOLs, there's a blue blocking component of the IOL. And so people have asked, are you inducing a sleep disturbance? And that's been studied at Oxford. And it looks like the amount of absorption of blue light is not sufficient to do that. So we don't have to worry about those IOLs. It's not absorbing a huge amount of blue light. So for example, I'm going to show you just a few slides. This is light intensity, and this is the pupil response. And with blue light at low light intensity, there's a greater pupil response compared to matched red light, because rods are being activated, feeding into the pupil light reflex, and they're more sensitive to blue light. And then when you get up to photopic levels, right here, there's probably an equal rod and cone input, so the pupil response is about the same. And then when you get up into higher levels, there's a greater response to blue light. So it's very light intensity dependent. And just to kind of show you what the pupil responses look like, at the low light level, you're mainly getting a response from rods. And as you get up to the photopic levels, but it's not too high a photopic, you're getting an equal pupil response to red and blue light from rods and cones. And as you go higher, as we were just demonstrating, you get this sustained response, which is the signature of melanopsin. And here's an example of a patient with severe photoreceptor disease, and compared to a normal eye, obviously you can see the OCT difference. And you can see that at low light levels, there is actually the thin lines is the pupil response. No pupil response compared to the heavier red and blue, which is the pupil response from an age-matched control. And as you increase the light, the control patient gets a greater pupil response, but there's still nothing from the patient with retinitis pigmentosa. And then when you start to get into a little bit brighter blue light, you start to see that now you get a response from this abnormal retina that's from the melanopsin. And so, we've studied a number of patients with retinitis pigmentosa and published this, and this kind of shows the normal eye's pupil response. In the RP patients, they start responding with bright blue light. So you can do this in humans and show the physiology. So just to kind of turn it around, like I said, in terms of clinical applications, is that with a low level of light, you can assess rod and cone function using the pupil. And with a higher level of blue light, you can assess this intrinsic melanopsin. So the idea is that optic nerve disease will affect both rod and cone and melanopsin input. But outer retinal disease will only affect rod and cone input. So you could use this to your advantage if you had a red and blue light. And some modern day pupilometers now have white, red, and blue light, and you can use the computer to measure these responses to very discrete wavelengths to get the information that you need for, screening and diagnosis. And it's just something like a little LED that has a red and blue light on each side could be used clinically. You don't need a fancy instrument. You can buy these. So I thought it'd be interesting just for you to hear about this because you probably don't, think about it that much, but it's important in our daily life, these responses. Yes?
Can it be because of the melanopsin containing cells that people and children with rod-cone diseases are so have that huge photophobia?
Yeah. So the question is, that would help explain or why do patients with rod and cone disease have photophobia. And photosensitivity is a hot area of study, and it looks like it is mediated by the melanopsin ganglion cells. And I have another talk, but we're not going to have time to do it, but these melanopsin ganglion cells also give input to the posterior thalamus. And that's the pain area that also receives input from the trigeminal nerve that innervate the dural blood vessels. So migraineurs, for example, they get more light sensitive, even when they're not having a migraine, but during a migraine even more. And in an animal model, if you put an electrode in these thalamic neurons, they respond to light and to pain. So melanopsin input actually modulates pain responses. Very interesting. And so that's another big area where this is being investigated in neurology of pain and how light affects pain responses. It's a good question. Anything else? Time for a short break, I think, 5-minute break. And we'll talk about efferent responses. Okay, thank you.